Good afternoon, everybody. My name is Jill, and I work at Children's Hospital Los Angeles. If I had Dr. Mathern's map, I would show you where USC was located in reference to UCLA. But here's our hospital. This is our brand spanking new, shiny, beautiful hospital. It's going to be opening next week during Carmageddon, so don't come and visit us, but certainly feel free to stop by. So I play a role, I'm a physical therapist in our Department of Rehabilitation Services, and actually Dr. Montez used to be our director before he jumped ship and went to the other side. And many of you have been to our facility, and your entrance to us, where we have acute PT, OT, and speech, your entrance to us has been in our Inpatient Rehabilitation Center. We are excited that we have the only fully pediatric inpatient rehabilitation center in Southern California. And so right now, what's been happening is because our hospital doesn't do hemispherectomies, we get most of the patients from UCLA about a month after, and they stay in our inpatient rehab center anywhere from 2 weeks to 2 months and onwards. It's pretty individualized based on the child. It's a multidisciplinary approach. We have a physiatrist, pediatrician, PT, OT, speech, social work, music therapy, pet therapy. It's run like a pretty typical rehab center, 3 hours of therapy a day. We have school as well. And I work permanently, but also cover rehab and acute occasionally on the outpatient PT side. So many of the kids, after they leave inpatient rehab, will come to see us in outpatient. We're a pretty typical hospital-based outpatient clinic. But if many of you are from Southern California, you kind of know the service delivery is crazy here. So some of you go to CCS, some of you go to regional centers, some of you don't get therapy, and some of you come to us. So that's a whole nother lecture in and of itself. So for today's talk, Monica kind of said to me, I really want you to focus on what's new and novel in therapies. If you can talk a little bit about constraint induced and kind of talk about your philosophy of physical therapy and occupational therapy and therapies in general and what we sort of do from our perspective at our hospital. And it's kind of the big question. I mean, it's not like this is such a common disorder that we see, coming through the door. It's not CP. It's not like, we also see a ton of TBI, acquired brain injuries, but it's still very different. And so when we started to get these patients a few years ago, it's like we didn't want to reinvent the wheel, but we wanted to use what we knew worked on other populations and sort of apply it into this very specific population. So I thought about how am I going to do this talk today, because it's such, it's been such a big learning experience for me to work with these patients, and it's been so great to get to know the kids and the families. But I thought instead of just really focusing on one treatment paradigm like constraint induced, and we'll go over that, but to really talk about what's the common theme between all of these treatment paradigms, what's in motor learning, kind of touch upon what Stella had talked about, and I'm sure that Joy will talk about, because it's a common theme of how are we going to get the best bang for our buck? How are we going to get the best functional rehabilitation for our kids? After having the surgery, we want to make the surgery worthwhile, and we want the kids to have the best quality of life they can have. So how are we going to impose that on this population? So you guys have probably been hearing a lot about motor learning, about neuroplasticity, and so what is motor learning? It's just a set of internal processes that associated with practice and experience, and it plays a part with what the environment plays upon the child. So it's what we want because it causes permanent changes to learning. And it applies to any motor task that we're teaching our children. So it applies to walking, crawling, reaching, grasping, writing, eating, any motor task that we want the child to learn, we can apply the principles of motor learning to. And what's neuroplasticity? So it has lots of different terms, but Stella called it cortical plasticity. it's the same thing. It's just the brain's amazing ability to reorganize itself by forming new connections, and it's the ability for us to learn in the healthy brain and for the brain to compensate in injury. So what's the goal? What's the goal? Why do we care? And the goal in any case, in any type of injury, is to reorganize the brain to restore and compensate for the function that's already been compromised or lost. And how do we do that? In normal brains, like Stella talked about, we are doing it every day. We do it through learning. We do it through experiences. And so how are we going to use that in a therapy model? And how can we maximize that in the therapy model? And then I really thought about what are the goals for our kids. And I went to this course a few months back that we hosted at USC, and one of the speakers said that the goal for our kids should be that if they're on the playground, then someone steals their stuff, but didn't say stuff, then my kid's going to be able to get their stuff back or steal that kid's stuff too. And we don't want our kids to be the ones sitting on the playground getting their stuff stolen. We want them to be able to like run after those kids and get it back. So that's the ultimate goal, right, for all of our kids. I mean, not to beat up other kids, but to keep up with everybody else. So the general principles, and I'll touch upon some of them, some are more important than others. Stella talked about a few of them, but these are the general principles of experience-dependent neuroplasticity and how they play a role in rehabilitation. So use it or lose it. So neural circuits not actively engaged in the task begin to degrade. So if you don't engage the system, it can lead to further degradation in function. And we kind of know that. We know that from how the kids come out of surgery. We know that from the kids going into surgery, that if they already aren't using one part of their brains, then that's how they get hemiplegia. But conversely, you can use it and improve it. So through extended training, through skill training, you can get big improvements in sensory motor performance. And they're showed by profound growth and change within the brain. Specificity and specificity of practice. So you'll kind of hear us talk a lot about making the practice and making the task very specific to what you want to do. If you want to work on walking, we got to work on walking. If we want to work on reaching, we got to work on reaching. And it seems simple, but sometimes you go to other places and people are like having their kids lay down on a mat and do exercises, and you're like, well, how is that supposed to help with walking? I want my kid up. I want my kid moving around. How are they going to get their stuff back on the playground? And repetition matters. So just doing the task is not enough to drive the change. There needs to be a lot of repetition, a lot of newly learned and relearned behavior needs a lot of repetition to be done. And it's not just like you can repeat it multiple times once the task is acquired. So once the child knows how to walk, they have to do it over and over and over again. So it's not like they can just learn how to walk and then be done, and they'll keep that learned behavior. And this, I'll talk about an example in walking about why all of this is so important. And sometimes, and especially this critical period right after surgery or right when they come to rehab, you just need therapy and rehab to get over the hump, to teach the new skill, to acquire the new skill, so that you can go home and then repeat the new skill as many times as you possibly can. Intensity matters, so that kind of goes along with repetition. So it's the intensity of the stimulation that can affect the amount of plasticity that occurs. And conversely, even if you get low intensity stimulation, it can actually weaken the synaptic responses and actually dull the responses in the brain. So we need high intensity stimulation, and that's what induces the long-term changes that we want to see. But what's the potential side effect? Is that if sometimes the timing of your intensity is too much, too early, it's too acute after the injury, then maybe the body is going to have some sort of overuse syndrome because it's not ready. So just to kind of play with this a little bit, going into the next one, just kind of know the timing of how much we're pushing our kids and how early or how ready they are for it. So like I said, timing. So timing, different forms of neuroplasticity occurs at different times. If you think about neuroplasticity and the change that's happening in the brain of our kids, it's not just one single thing. Like one single thing that happens. It's constant, it's growing, and it's ever changing. And so the timing of your interventions are really important, and it has to be applicable to the patient, to the family, and meaningful, and that's when it's going to show the most change. A lot of studies that they've done in monkeys have shown that if you do stimulation early, that it shows better effects, but just remember how we said that if you do it too early, in a lot of the human studies, if you've done it too early, that sometimes it can kind of be detrimental to the change that's just the recovery that's happening in the brain. Salience. So I had to look up this word like 400 times, and I teach it at USC, and I kind of thought I knew what it meant, and then I looked it up and read about it, and I was like, oh, I totally didn't know what that meant. I just used the word meaningful, but that's what it is that how meaningful is the task to the child, to the person that you're asking to perform it? If they don't care anything about picking up the Cheerio with their two little fingers and putting it in their mouth, they're never going to do it. So how can we make the task meaningful to the child, meaningful to the family? And you need that motivation. You need the buy-in from both the patient and the family, because if not, how are you going to get the repetition and the intensity of the training? And age. So training-induced plasticity occurs more readily in kids. We kind of know this just from looking at normal development and knowing how, younger kids are so apt to learning languages. Their brain is so open to change. And in normal brains, I also was told this, that by the time you hit 30, you start losing some brain cells, and that you've either plateaued or the whole you can't teach an old dog new tricks. They kind of said it's true, so it kind of made me a little worried because I just turned 30 a few years ago. But so it's a normal process to have different responses in the aged brain, and it's normal to have some sort of atrophy in your brain as you get older. So we naturally want to have earlier interventions at an earlier age. But that doesn't mean that we all should be sent to the farm, because the aging brain can still respond to experience, and even though they may be less profound in the younger kids and slower to occur than those in younger brains, there's still changes. So there's still hope for us all a few years over 30. So transference. What we want is that there's a variety of training, and that the plasticity can respond to, if you train somebody on how to walk over ground, they'll know how to walk over grass. If you train someone on walking in general, they'll know how to walk upstairs. So we want them to be able to transfer their motor skill to a new environment, to a new novel stimulus that's similar in nature. And interference. So this is kind of the negative side, is that with transference comes interference, that sometimes the plasticity with one part of the brain may impede in the learning of that same part of the brain. So a lot of our kids come out with a hemi neglect, and a lot of kids come out with these really bad habits that they've learned really early on after surgery or even before surgery. And they're these compensatory mechanisms that the kids learn so easily, and we as therapists are trying to reverse every single day. But if that's ingrained in them, and that's what they're practicing most often, and then they come to therapy one time a week and we're telling them to do something completely different, then that's going to always override us. So how does this reflect in the motor tasks for our kids? We want our kids to be able to do everything that other kids can do, and be able to do them well. We want them to run, walk, put on shoes, and do some other things when they're upset too. So I'm going to use an example of walking, and then we'll get into the upper extremity constraint induced. But if you think about the typically developing brain and the typically developing child learning how to walk. So this is like teaching our kids who have never learned how to walk, and now they've had a hemispherectomy, and we have to teach them to recover everything and learn how to walk. Well, let's go back to the models of how we all learned how to walk. And we use the basis of motor learning principles, and we use repetition, intensity, specificity, and the effects of practice. So there were studies done by Karen Adolph that show that in typically developing infants learning how to walk, they accumulated more than 6 hours a day of walking, that they averaged between 500 and 1,500 walking steps per hour. and that each day they walked 9,000 steps and traveled the length within one day of 29 football fields. So just think about that. For a typical brain, a typically developing child, that they walk 29 football fields every single day when they're learning how to walk. How are we going to get that into our kids? Think about how intense and specific that training is in just a normal motor task that we all do, that we all have gone through and all of our kids are going through. And although it's intense, it's not like they walked for 6 hours straight a day. They practiced walking for short periods, took long breaks, went back to it, stood up, kind of cruised a little bit, handheld. So they did all these things in upright. But it wasn't like you just walk for 6 hours. And the time that it took, it's not like you took your first steps and then you're a proficient, had your mature gait pattern after that. You took a few weeks, a few months to be good at walking. If you've seen any infant walking, it takes a while. And usually when they get their first steps, they don't start actually walking for a few weeks after that. And the transference. So the kids that they saw, they took a poll and had parents write diaries, but the kids they saw walking were somewhere from like Manhattan in New York, and they lived in these condos and had 3-story stairs to go up, and some were from the countryside and worked outside. So they weren't just walking back and forth over flat surfaces. They were walking up and down stairs, on grass, on rugs, on all different surfaces. And even though they weren't experts at it initially, kind of like how Stella talked about juggling, that helped them in the long run to be able to transfer their walking to all different surfaces. And so it's the variety and the randomness of their practice that facilitated the greater flexibility under all the conditions. So what does that mean? What does that mean for our kids? If a typically developing child is walking 29 football fields per day, then how much do our kids need to do? Not just for walking, but any motor task. How much do we need to be pushing them? Or how much do they need to be doing at home when they're not in therapy? Because there's only so much we can do in therapy. Does 1 to 2 hours of therapy fill that requirement? Probably not. So how are we going to enable our kids and our families and all of you to practice outside of therapy and practice everything, make it meaningful, and do it just as much as typical developing kids are doing, if not more? And how can we use these principles of motor learning and neuroplasticity to benefit our kids? And for every motor skill and every motor task that we need to do, whether it's walking, reaching, giving the finger, whichever. So how does this relate to the treatment paradigms that we're talking about? So a lot of the research shows that in our kids, yes, they may have a limp and they have asymmetrical gait, but a lot of their bigger issues are in their upper extremity, and I think a lot of you guys will agree. So what are the specific treatments for children with hemiplegia that we can use for our kids and that use all these principles of motor learning? So constraint-induced, force use, and bimanual. So what's the difference between constraint-induced and force use? You guys kind of heard a little bit about constraint-induced and force use from Stella, but both of them were based on studies in monkeys, that they basically took out half their brains or deafferented their brains, and then it demonstrated to them that there's this phenomenon called learned non-use. So not necessarily that they couldn't use their arms, but when they attempted to use their arms, they weren't as successful as their other arms. So then they just decided, you know what, it's easier just to use my other arm, I'm just not going to use it. And so how do we reverse that? And learned non-use is something that they found to be very prevalent in kids, not as much in adults, and not much in the adult stroke population where a lot of these studies have come out of, but more so in kids. Because adult stroke population, they can kind of rationalize, they can say like, I know I should use my arm, I know it's harder, but I have to practice this. And in our kids, they just want to take the easy way out, path of least resistance. So that's what they're going to go for. So both of them use restraints of the intact limb, and they use training of the involved limb to overcome the learned non-use, to try to use it in function and in real life. The only difference between the two, between constraint-induced and forced use, is that the types of practice that is involved. So in constraint-induced, it's structured practice. So they call the typical protocol for constraint-induced is 6 hours of therapy a day from anywhere from 7 to 10 days. There's modified programs or 3 hours of therapy with, again, structured practice. And the structured practice is very focused on a very specific reaching, manual, fine motor task, and it's made harder and more difficult with every trial, and it's very structured. Your child has to be able to withstand 3 to 6 hours of therapy of that. Whereas forced use is they put the restraint on, and you may get occupational therapy, you may get physical therapy for your normal time, but there's not a structured protocol to which is used. And so a lot of the kids, well, it'll be put on, but then they get sent home. Here, use this as you would in your natural environment. So with children with hemiplegia, they've been found to benefit very strongly from both of these paradigms, from CIMT and from forced use, due to the repetition, due to the specificity and the intensity of both paradigms. And both of them incorporate this very intense practice, which we kind of talked about earlier, and we're kind of honing in on a lot today. And with the age of our children, it just also tells us that there's an increased potential for plasticity. So they probably will have the better outcomes than the adults and the monkeys. Where there becomes how you're going to decide which one you're going to use for your child, if you're going to use one for your child. They've often found in a lot of the studies is that constraint-induced was too rigorous of a program for our kids. So in the younger population, I mean, I can't even imagine having a 2-year-old sit down and pick up Cheerios, pick up blocks, put things inside things for 6 hours straight. Even 3 hours is pretty tough. And you have to take into consideration the age of the child, the meaningfulness of the task, and how to make it something that the families can do at home. And also a big component to a lot of these, and with our families, is behavior. You're going to put a restraint on a child, get them so frustrated, and a lot of times they're just not ready for it. And so thinking of the timing of when to apply the restraint, and I mean, even timing is like, do we do it in the summer? Do it during the school year? When are we is it gonna afford them the most success? And the type of practice that's emphasized should be based on the child's developmental age. So a lot of kids won't even qualify for the CIMT protocols based on their cognition or based on what they can or can't do and how much they can move their arm, their affected arm. So that's what we use also. And the tasks that we choose are based on the child very specifically. So here's some of the types of restraints that are used. At our facility, we tend to use the splint that's in the middle, the gray splint. And sometimes we'll use a soft cast that the parents can take on and off, or a bivalved splint, where we put a cast on, but we bivalve it, we cut it down the side so that it can be taken off at some points. Because like I said, it's really frustrating for the kids to have this on, and it gets really dangerous for the family members and the kids themselves to have a hard cast on. So the other new hot topic, kind of what Stella was saying, is bimanual therapy. And this is like hot off the presses. 5 years ago, it was all about constraint. Everybody talked about constraint, and everybody had to do it, and it was like the newest and greatest. And now, of course, like anything, like computers or phones or anything, here comes something new coming along, just to burst our bubble. But this was basically, bimanual was made in response to the limitations in constraint. So in not just the Hemi population, but in the CP population, there's also data saying that they don't really have a good arm, that there's always a little bit of an effect in the good arm. And so some of the theories are that you're going to put a constraint on the not as good arm, the good arm, and you're going to make it worse, and then you're only to bring the affected arm just a little bit better. So now you're going to be left with 2 not as good arms, basically. So that's some of the premises where they thought, why are we tying up their good arm? That's what they need, that's what they're using. The other kind of thought between for bimanual is that a lot of our function in daily life is bimanual. A lot of what we do every day is bimanual. Pretty rarely do we work in a silo with just one arm. And so if you train, like we were talking about specificity of training, if we want to train tying your shoes, putting on clothes, and doing everything, then we have to do both. So the preliminary studies that I've read kind of showed what you would expect from this is that CIMT showed better performance to unimanual gains. So that makes sense, that they showed better performance in the one arm, and that bimanual training showed better performance in both arms, but not better performance in one arm. So right now they're kind of saying, like what Stella said, is that we have to consider using both. And our hospital actually started a camp in the summers that's called Handy Heroes, and it's a 2-week camp. It's 6 hours a day, and we do CIMT, forced use, and bimanual. Last summer was the first time we did the camp, and this summer we're starting it again. And they've been showing, we use the AHA, the Assisting Hand Assessment, to test how well the affected hand is, and it's been showing really great results. And we kind of treat it like a summer camp type approach. So we're doing Constraint with some specific things like doing arts and crafts, and then they have lunch, and we do a lot of bimanual. So this is something that what Stella and Dr. Monster talked about, it's pretty novel, but it's what's better to have your kids in a summer camp, and then they're getting therapy while they're at it. So what did we learn? That the child's brain is ever developing and extremely plastic, so there's great potential for learning for all of our kids. And it's that plasticity that allows us to relearn and develop new skills after injury. And that learning a new skill, any new skill, requires a lot of repetition, a lot of intensity, and a lot of specificity. And think about those 29 football fields and what we have to do to our kids and how many more football fields they have to walk. And with just the principles of motor learning, you can apply it to any physical therapy or any rehab facility, and hopefully that motor skill can be learned in rehab and at home and carried out through them. Thank you.